Good evening and welcome. My name is Erica Zerzin, and I am the Public Awareness Coordinator for the Alzheimer Society of Saskatchewan. And it is my pleasure to welcome you all to our Understanding Dementia community presentation featuring our guest presenter, Dr. Megan Surkan. Before we get started, I just want to remind you all that this presentation is being recorded, but only the presenters will be shown on video, not the participants' videos or names. During the presentation, you can please type your questions in the Q&A function at the bottom of your screen, and we will have a question period at the end of the presentation. We ask that you please keep your questions relevant to the presentation, and if you have any follow-up questions, do not hesitate to reach out to our society staff at our resource centers across the province or by calling the Dementia Helpline at 1-877-949-4141. Because the Alzheimer Society of Saskatchewan is a provincial-wide organization, I would now like to offer a land acknowledgement from a provincial perspective. The people of the Alzheimer Society of Saskatchewan are privileged to live and work across the traditionally sacred land we now know as Saskatchewan. We recognize the enduring presence of the Cree, Dakota, Dene, Lakota, Nakota, Saulteaux, and Métis people, who are the original stewards of the rolling hills, rushing rivers, and living sky we all share today. As an organization, we acknowledge the harms of the past and how Indigenous people are still impacted by the process of colonialism. Through partnerships, education, and collective action, we commit to honoring our relationship with the land, our treaties, and each other as we journey towards Wokotehisiwin, which is reconciliation in Cree. This presentation has been made possible by Conexus Credit Union. Together, the Alzheimer Society of Saskatchewan and Conexus hope to further cultivate a support network around people living with dementia and their families to ensure everyone can live well in our communities. We recognize there is strength in numbers, and we will be working together to build a stronger community of support for people living with dementia and their care partners. The partnership with Conexus aims to increase the knowledge and understanding of those experiencing dementia by offering educational activities and resources to individuals and families in Saskatchewan who are living with dementia. Our shared goal is to create a more complete network of supports for those living with dementia and to ensure they and their families are supportive to thrive in our communities. The work the Alzheimer Society does is built on connections, and we feel very lucky to have Conexus as one of our connections as we support them in investing back into the community that invests in them. I would now like to introduce our guest presenter, Dr. Megan Surkan. Dr. Surkan completed medical school and internal medicine training at the University of Saskatchewan and a geriatric medicine fellowship at the University of Alberta. She currently works in Saskatoon as a geriatrician. So welcome, Dr. Surkan.
Hi, everyone. Thanks so much, Erica, for the kind intro. Thanks so much for coming tonight. And I wanted to talk tonight about dementia, of course, and we're just going to go, give me one sec here, over the objectives for tonight. So we're going to go over a few different things. We'll first talk about what is dementia, what are some common types of dementia, what are risk factors for dementia, which ones can we do things about, and which ones can we, modify versus not. What are some warning signs or early symptoms of dementia? Why does it matter to get a diagnosis, particularly the earlier the better? And then we'll also go over what programs and services are offered by the Alzheimer Society. So to start out, how common is dementia? Dementia is quite common, and essentially, if the older people get, the higher the likelihood. So by the age of 65, this is Canadian Stats Canada data. About 1 in 12 people over the age of 65 live with dementia, and by the age of 85, up to 1 in 3 people are living with some form and some severity of dementia. So what is dementia? So to start with, dementia is an umbrella term. So sometimes people think that the word Alzheimer's or Alzheimer's disease is the same as dementia, and that's actually not the case. So dementia is the umbrella term, and of the different types of dementia, Alzheimer's disease is one of them. There's, dozens of different types of dementia. Dementia refers to a progressive neurodegenerative condition that affects the brain and affects various elements of cognition, language, memory, executive function, um, visual, spatial awareness, personality, mood. So there's changes in one or multiple domains of cognition, and this slide lists the 5 more common types of dementia, Alzheimer's being among the most common types of dementia, vascular dementia also being very common. Mixed dementia is another very common type, and dementia with Lewy bodies or frontotemporal dementia are other types of dementia we'll cover tonight. So what causes dementia? We're not entirely certain what the cause of dementia is. And because of so many subtypes of dementia, I'm of the opinion we're not going to find a single cure. We're likely going to have to work on different elements of a cure. We'll have to look at, for vascular dementia, that's a different prevention strategy than, say, some of the conditions like Alzheimer's disease that, we are targeting things more like amyloid protein, and other dementias have different abnormal proteins in the brain. So we are making progress in research. It is probably slower than many of us would hope, but it isn't entirely certain yet what exactly causes dementia. One thing to note, however, it is not a normal part of aging. So dementia means that someone has functional impairment that is different from, so they've had a functional decline from things that they could do in the past that they no longer can do. So that would never be a normal part of aging. Some people do, kind of normalize certain parts of cognitive decline with age, and that is not. It's sort of a misnomer that would be sort of a pathology rather than a normal part of aging. So to help demonstrate that, this is a cross section of the brain. So on the left side here, this is a normal brain. And you can see the areas highlighted in the temporal lobe is like for memory and language there, and they're nice and plump and normal looking. On the other side here, there's a brain that's been affected by Alzheimer's disease. So you can see how much shrinkage there's been in those areas. So for memory and language in that temporal lobe. In Alzheimer's disease, there's a buildup of this protein called amyloid, and also tau. So you get these neurofibrillary tangles and amyloid like plaque deposition in the brain. Eventually, all that plaque and those tangles cause the brain tissue to die off. And then you see the shrinkage demonstrated in this image. So dementia in the brain, this is a visual of the brain and, some of the important areas it can be affected. The symptoms of dementia vary on what type of dementia it is. So, for example, Alzheimer's disease very much affects the temporal lobe and the parietal lobe as well. So you'll see symptoms like people have difficulty with short-term memory, with language, comprehension of words, not able to remember words. And also the parietal lobe looks at more perception and making sense of the world. So if you see an image that your brain tells you this is what that means. So if those areas of the brain are infected, you might see more of an Alzheimer's disease presentation clinically. The frontal lobe, as a different example, that has to do with the frontal lobe helps us with executive function, so higher order complex planning, problem solving, organizing things step by step. It's also really important for emotions, mood, personality, impulse control. So it's sort of like a gas pedal and a brake pedal when it comes to mood and personality, that someone might become more disinhibited. They might have more highs and lows in their mood, like lability. They might their personality might entirely change if they have damage to the frontal lobe. And that could be frontotemporal dementia. It could be if someone had a stroke affecting the frontal lobe or even a head injury. So depending on the area of the brain that is affected, you'll see different symptoms. Um, so what, again, causes of dementia? On the right side here, you'll see these are chronic, irreversible causes of dementia. And many of these have to do with either some sort of injury to the brain, whether it's, over a vascular injury or a head injury or chronic toxin exposure like alcohol-related dementias, or these protein deposition problems like Alzheimer's disease, where you get the amyloid and tau. Frontotemporal dementia, you get this buildup of tau protein. Lewy body dementia, you get this other protein called alpha-synuclein, which is also similar to the protein in Parkinson's disease. So these are things that progress over time, and unfortunately, we can't reverse. On the left side here, however, sometimes there are things that we can find and reverse for people. So there's reversible causes of cognitive impairment. One I see quite commonly is actually side effects of medications. So there's a lot of medications out there that aren't, very good for cognition or thinking. They might make you cloudy or drowsy and have difficulty with thinking clearly. So if we'd identify those and stop them, people sometimes do a lot better day to day. If someone is acutely unwell, they might get something called delirium if they have infection, a fever, pneumonia, those sorts of things. Depression, anxiety, or, sort of significant stress in people's lives can cause difficulty with cognition. And if we can, identify that and appropriately treat people, then, that shouldn't be a permanent cause of cognitive impairment. Dehydration, or say like a kidney injury from being dehydrated, could certainly cause some temporary confusion. A brain tumor, low B12, if your thyroid isn't working quite right. These are all things this is why it's important to be assessed early, and, the benefits of an early diagnosis. There may be something that we can do something about and try to reverse. So all the more important to present for care and an assessment early in the stage instead of waiting. So we'll start by going over some different types of dementia, just the broad categories. So there's these progressive neurodegenerative disorders like Alzheimer's disease, dementia with Lewy bodies, frontotemporal dementia, even CJD, Creutzfeldt-Jakob disease, or it's a prion disease. Vascular dementia is, it depends on the type of vascular damage. It can be progressive, or it can be more of like a stair-step decline over time. So there's either small vessel damage or large vessel damage if someone had a big stroke. Another type of dementia would be head injuries. So people that have had traumatic brain injuries, or even some of you may have heard of chronic traumatic encephalopathy, or CTE, or what they call boxer's dementia. People have had a lot of head injuries over a period of time, usually from playing sports like boxing or hockey or football, can end up with a certain type of dementia as they age. So to start with, the first and most common type of dementia, Alzheimer's disease. Alzheimer's is the most common type of dementia. It's estimated to be around 65%, or 2/3 of all dementias are Alzheimer's disease. Alzheimer's, unfortunately, it is progressive. It's a degenerative disease of the brain, and it's not reversible. So it's more than just memory loss. Alzheimer's, we'll go over the 10 warning signs of dementia, but Alzheimer's people will start having trouble with their short-term memory. They maybe can't find words as easily or understand words. They might get lost. They might lose function with things they used to be able to do easily before. So it's more than just a little bit of memory loss. It has to be severe enough to impede someone's functional abilities. What are some risk factors for Alzheimer's? So age is one. We do know as all of us get older, dementias of all types get more likely. Head injuries, early life and later in life, are a risk factor for Alzheimer's. And unfortunately, this is something I see fairly often when people suffer a fall. They might hit their head, get a concussion, and then it sort of accelerates their cognitive decline, maybe a few years sooner than something may otherwise have happened. High blood pressure can damage the blood vessels in the brain and contribute to risk of Alzheimer's. And similarly, these are other vascular risk factors. So high cholesterol, smoking, if people have high body weight or obesity, physical inactivity, we know exercise is great for the brain, and the opposite, you're not getting that protective benefit of exercise. Diabetes as well, and stroke all affect sort of the vessels in the brain. Other things we know can increase risk is a lower educational level. Down syndrome does increase the risk of Alzheimer's disease, and the reason for that is actually genes. So individuals with Down syndrome have trisomy 21, or 3 copies of chromosome 21. On that chromosome, there's a protein called APP, or amyloid precursor protein. So usually you only have 2 copies of the APP gene. If you have 3 copies of that, you have like 150% of the dose, so to speak, of amyloid. So they just have more amyloid production. And it's not uncommon for people suffering with Down syndrome to develop Alzheimer's disease, even in their 40s, like at a fairly young age. Depression and low mood, this is sort of a chicken egg situation. We do know people with longstanding depression are at higher risk of Alzheimer's. However, mood changes can also be a symptom of Alzheimer's. Hearing impairment is another, this is an important one to note because it's modifiable in most cases if people have and wear hearing aids. There's more and more data coming out that if you can't hear well, then the brain, I think it's sort of a use it or lose it sort of situation. If your brain's not working in translating what we hear, then people may lose function in their brain. Genetics as well. So genetics, there's not a very high percentage of genetically or inherited Alzheimer's disease. So there's different genes that affect young onset Alzheimer's, generally before the age of 60 or 65, or older onset or of Alzheimer's. So in young onset Alzheimer's disease, there's those 3 genes, the APP, amyloid precursor protein, and then presenilin genes, so PSEN1 and 2. So if people have those genes, they're more likely to have to develop Alzheimer's disease. However, it's not a given or guarantee by any means. A gene is not what we call deterministic, so it doesn't guarantee someone will get the illness. ApoE4 is another, so apolipoprotein, there's E2, E3, E4, and we have 2 copies each of this apolipoprotein gene, so we could have an E2 and an E4, or both to E3, E3, E4, E4. So we have some combination of those 3 E2, E3, E4 genes. People with E4, either 1 copy or 2 copies, we know are at an elevated risk of Alzheimer's disease. If you had 2 copies of E4, it's up to an 85% lifetime risk. But we also know there's many people with 2 copies of E4 who never develop Alzheimer's. So what I'm getting at is it's more than just genetics. It might predispose you to something, but it's not a guarantee of developing the illness. What are stages of Alzheimer's? So the Alzheimer Society breaks it down into 4 stages: early, middle, late, and end of life with Alzheimer's. So early, people are noticing, some impact on their function, some symptoms, but they only need a little bit of help. In the middle stages, they're starting to need more help. Late, they need quite a bit of help. And late is more end of life, where people, may lose the ability to walk or, interact. Or speak in the very end stages. It really varies on how long people spend in each of these stages. In general, it's often a couple years, and in all comers, from the time people are in early stage Alzheimer's disease, to when they pass away from the illness is around 8 to 10 years. But that prognosis can really vary depending on, if people have other health conditions, how old they are when they are diagnosed, um, if what type of dementia they have. So some dementias progress more quickly, like things sometimes like frontotemporal dementia or dementia with Lewy bodies are often have a different trajectory than Alzheimer's. So this is sort of a important concept to understand that there are stages of progression. You may also come across something called the Global Deterioration Scale, which breaks dementia down into 7 stages. But I find the 4 stages are easier to sort of understand in using this as a day-to-day tool to help understand the illness. So next we'll move on to vascular dementia. So this applies to a couple different subtypes of vascular dementia. As I said, there's these large vessel damage would be like a large stroke. And so that's when you get a clot that blocks off one of the big arteries in the brain, and then the brain cells and tissue don't get blood flow, oxygen, and behind the clot, essentially that brain tissue can die off, and then people develop symptoms like they can't speak, they get weak in their arm or leg, they can't swallow well. Their balance is often affected. It depends on what area of the brain the stroke affects. And sometimes if people have more than one stroke, you have this cumulative effect. So each time it's another hit to the brain, and then the deficits can sort of build up. So that's one type of vascular dementia. Another, probably more common type, is microvascular damage. So the small blood vessels in the brain get damaged, and then the white matter, so the deep white matter in the brain, in the inner parts of the brain, get damaged. So this is from things like uncontrolled blood pressure, diabetes, smoking, high cholesterol, and they can affect these small vessels. So vascular dementia, if you have a large vessel stroke, you could have sudden onset of vascular dementia following, as a consequence of that stroke. Or if you have multiple little mini strokes, it's like a stair step. Each time things get a little worse. So the progression of vascular dementia can vary depending on each person's, vascular injury. What are some risk factors for vascular dementia? So again, aging, unfortunately, there is a buildup of atherosclerosis or plaque in all of our arteries the older we get. Diabetes, so this is why it's so important to control some of these vascular risk factors in our younger years. If people have really high sugars for a long time, it can damage the blood vessels in the brain. High blood pressure, so a systolic blood pressure, particularly over 160 for a prolonged amount of time, can damage blood vessels in the brain and elsewhere. High cholesterol, smoking, and heart disease. So let's say someone has coronary artery disease. They had to get stents in their heart or bypass surgery. We know they're already what we would call a vasculopath, so to speak. They already had a clogged artery somewhere else in their body. So in all likelihood, the blood vessels in the brain also have plaque buildup or potential microvascular damage. The third type of dementia we'll go over is frontotemporal dementia. So frontotemporal dementia often affects people at a younger age. So often, but not always, under the age of 65. This is a really tough dementia. It's often people that, they're likely still working. It's a different stage of life, being in people's 50s rather than, say, their 80s. So frontotemporal dementia, one of the first symptoms people might find is they're having trouble doing their job. The symptoms really are, when you look at what does the frontal lobe do and what does the temporal lobe do, those are the symptoms you'll see. So people often will have a significant change in their personality where they may become more what we call disinhibited. They might say things that aren't, generally appropriate, or they never would have said in the past. They may have trouble regulating their emotions. Often people can develop some like perseveration or obsessive OCD type tendencies when the frontal lobe is affected. And then executive function or like complex problem solving, planning, step by step, tasks can suffer. And then the temporal lobe has more to do with language, memory, and perception. So people can have a deterioration in those things as well. Another thing the frontal lobe does is initiation and motivation. So it's, people will lose their get up and go sometimes, and they won't, they're not necessarily depressed, but they just don't have the motivation or get up and go to do things they used to enjoy. So this is a scan of a person I saw who was suffering from frontotemporal dementia. This is after a number of years with the disease. So on the left here, this is a plain CT scan. And at the top here is, if you can imagine, that's where your eyes and your nose would be. So you can see all this black here on either side. That's where brain, that should be filled up with brain tissue, and that's all shrunken away as the frontal lobes have been damaged over time. On the right here, this is what's called a PET scan or positron emission scan. So we give people glucose or a sugar molecule with a radiolabeled tracer on it. So this is looking at how are these cells metabolizing sugar. Or how much activity is going on, metabolic activity is going on. And this is a little harder to see, but you can see like here, it looks darker than this bright yellow. So all of this really should be bright yellow, and it's, quite reduced in the front part of the brain or the frontal lobes there. So just a visual of, what this might look like in the brain. The fourth type we'll look at is Lewy body dementia or dementia with Lewy bodies. So this is a type of dementia where there is this abnormal aggregation of these proteins that we call Lewy bodies, and they're made up of this thing called alpha-synuclein. That's the abnormal protein, and it starts gumming up the works and causing a variety of symptoms. So symptoms of Lewy body dementia, often people will have significant fluctuations in their cognition. So they might have a day where they seem almost normal. They're really lucid, their brain's working pretty well. And then, even hours or the next day later, they might be drowsy, they might be really altered, really confused. So these highs and lows, these dramatic swings in cognition can be quite common. Another common thing people develop is something called visual hallucinations. So they might see things that aren't there, and they might even interact with these things. Like they might be quite distressing. A couple more common features of this are something we call REM sleep behavior disorder. So a REM sleep disorder is essentially when we're in rapid eye motion sleep or we're in deep sleep. Most of us don't move. We don't move around, but in a REM sleep behavior disorder, people act out their dreams. And this can be really quite dramatic. Like people can hurt themselves, put holes in the wall, their bed partner might get hurt, or they might fall out of bed. And the REM sleep behavior disorder can start, even 20 years before they develop Lewy body dementia or even Parkinson's disease. You can have this REM sleep disorder as well. People might lose their sense of smell, develop constipation, and then they may develop Parkinsonism. So Lewy body dementia is a cousin to Parkinson's disease. They're both caused by the same protein. It's just in Lewy body, the protein is already widespread. In Parkinson's, it starts in a part of the brain called the basal ganglia that just causes like the motor symptoms, the tremor, the stiffness, the slowness, the shuffling, the falls. So people with Lewy body, unfortunately, can suffer all of those Parkinson's type symptoms as well. Unfortunately, the levodopa or the dopamine type medication we give people to treat Parkinson's isn't as effective in Lewy body dementia. This is a type of dementia that does tend to progress more rapidly, unfortunately. The next type of dementia we'll cover is mixed dementia. So this could be a variety of things. The most common mixed dementia is Alzheimer's disease with vascular dementia. So people, if we look at their CT scan, they may have a lot of the microvascular damage. They've had longstanding high blood pressure, or diabetes, or smoking, or different vascular risk factors. And clinically, they present with Alzheimer's disease. So some of their first symptoms might be trouble with their memory or word finding, or language. So that's a common type of mixed dementia. There's other mixed dementias like Lewy body can co-occur with Alzheimer's pathology. We know that when pathologists look at brain tissue of people suffering from dementia after they've passed away, over half of them actually have mixed pathology. So this is really interesting that we like to put these things in nice clean boxes, but when you actually look at the brain tissue, it looks like it's more complicated than that, and things can co-occur more than we realize. So those are, some very common types of dementia. Sort of along those lines, but this is not dementia, is something called mild cognitive impairment, or MCI. So mild cognitive impairment is where there's a decline in cognition, where, the person themselves and or their family may notice, their family member might be a little more forgetful. You might be relying more on like making your lists, or more reliant on calendars or reminders from your phone, but it's not severe enough that it's impacting functional independence. So if that person, was living by themselves, or say, I always ask the question, like, if your spouse went away on a holiday for a week, like, would you be worried, or do you think, things would be okay? And in MCI, the person can still function. They'd still be able to, cook and drive and, do all their regular things without trouble. And when we do cognitive testing, so say if we did something like a MOCA, a Montreal Cognitive Assessment, or MMSE, are two common cognitive tests that are done, the person might score a little below the general cutoffs of what a normal score is. But again, the crux of this is that their function is not impaired. Someone with MCI is at increased risk for developing Alzheimer's or another dementia in the coming years, but it's important to know that about 2/3 of people with MCI never progress. The other proportion of people, this MCI is likely a preclinical stage of Alzheimer's. So, Alzheimer's doesn't develop in 1 or 2 years. We know it develops over 5, 10, or 20 or more years. So in certain people, this may be a precursor to that. However, in many people, MCI simply never progresses. People have some cognitive symptoms, but they don't turn into anything significant. So, what are risk factors for developing dementia? There are modifiable risk factors, things that we can control, and there are non-modifiable risk factors, things like age, or genes, or genders. If people have other medical problems, or you've had a head injury, those are things we can't control. The good news is there's quite a bit that we can, and there was a Lancet report out a few years ago that said up to 40% of dementias are actually preventable when looking at modifiable risk factors for the disease. So how do we reduce our risk? In general, what's good for your heart is good for your brain. So exercise, as I said, is great for dementia. Exercise increases something called BDNF, brain-derived neuro growth protein, or factor. So it's literally a growth factor for your brain, which is released. Really, not a lot of things do it. Exercise is the main thing that releases this. Again, these vascular risk factors that, again, they protect our heart. They also protect our brain. So not smoking. If you have high blood pressure, that's nothing to just be like, oh, no big deal. I don't feel sick. My blood pressure is 170, but that's okay. Like, we need to, what we do in our 40s, 50s, and 60s matters in, our 70s and 80s. So if we can get really good control of blood pressure, diabetes, high cholesterol, not smoke in our younger years, then we are at a significantly reduced risk of developing dementia later on. And another thing to look at is We talked a bit about exercise. Exercise can be very social. So it'd be very, some people, you kill two birds with one stone. If you can do exercise with people, you enjoy being around or socialize while you exercise, that's even better. Social isolation is a really a significant risk factor, both for dementia. The other thing is when people develop dementia, it's really one of the very difficult things about it is sometimes friends tend to withdraw. They don't know what to say. People are less likely to maybe want to leave their house sometimes. So we know that staying socially active and engaged with friends and family and our communities is actually very good for the brain. So that's cognitive stimulation. So staying socially active is also really good for the brain at any age. How about in Saskatchewan? So when we look at statistics, right now in Saskatchewan or today, about 20,000 people live with dementia. That's a huge number. So, that's, I think, more people than live in Yorkton. I believe that's around the size of Warman, of the population of Warman, which was one of the fastest growing places in the province. So, and there would be just as many caregivers. There would be, at least 20,000 more caregivers or more of people um, living with their loved one with dementia. So, it's hard to find anyone whose lives haven't been touched by Alzheimer's or other dementias. Every day, every 24 hours, 10 or more people develop dementia. And the next thing we'll cover is what are some of the warning signs of dementia? Because I think a lot of people look at memory loss, but there's actually a lot more to look out for that sometimes doesn't get, the attention that these other warning signs would warrant. So again, dementia is about more than just memory. There's 10 evidence-based warning signs associated with dementia that have been endorsed by the College of Family Physicians of Canada. Understanding and knowing what these warning signs are will improve, recognition. So the first step, if you don't recognize anything's wrong, then people won't get a diagnosis. If there's things that are reversible, we won't, catch those in time. There's different medications we'll talk about a bit later, but it's very clear that the earlier people get assessed and diagnosed, the better if there's something going on. So the 10 warning signs are listed along the right side there, and they're broken into the ABCs. So the ABCs of dementia or warning signs. So you'll notice people have a change in their abilities, alteration in their behavior, and change in communication. So we'll go over these 10 warning signs. And again, just a warning sign has to be a change from that person's prior functional status. So, if someone has never been able to drive a standard in a car, and then someone says, "Oh, you don't know how to drive," but it's a type of car someone never knew how to drive to begin with. That's not, a warning sign that would be expected. But if someone drove the same car all their life and all of a sudden, they're not sure how to turn the key or shift the gears, or they're getting lost driving, that is a red flag for sure. So the first warning sign, a change in abilities, is memory loss that affects someone's day-to-day abilities. So, how might this present? Someone might be asking the same questions, or they'll ask for the same information multiple times. They might get told something and they can't remember it all. So if there's an important appointment or date or birthday or event coming up, they might ask multiple times, like, when is that again? When is that again? Or they might entirely forget that that event is happening. People can also forget how to use objects or not recognize what to do with it. So that is sometimes called apraxia, where people would look at a microwave or a stove and not quite know how the buttons work or how to use it anymore. Another warning sign is difficulty performing familiar tasks. So this might be a change in executive function, where people with that complex planning, they struggle with what order to do the tasks in. They, if it's something like cooking a complex meal, things might be done in the wrong order and it may not turn out. Or, there's certain steps to completing these complex tasks that people, mix up. So things that they used to be able to do that they no longer can do is again a red flag. Another one, so people forget what day it is or what time it is. They can just get disoriented in time, but also space, so they might get lost. So this isn't so much, it's pretty normal if any of us go to an unfamiliar city or even an unfamiliar part of the city we've never been before, to make a few wrong turns and get mixed up where you're going. If it's somewhere people have lived, for a long time, or a place they've traveled like dozens or hundreds of times, um, people, it's not normal to get lost trying to find your way to places you've been many times before. Um, and this may be like driving or walking. People get lost finding their way home. And then people also may say like you'll be talking about, the snow or something, and they don't seem to be aware that it's winter. Like they're like, oh yeah, is it winter? Or oh, is it January already? And they're still say in the fall or September, or they might get mixed up what year or what day of the week it is. So people get lost in their sense of time and space. Another warning sign is losing things or misplacing things. So, a very common symptom of dementia is people will lose things like their keys or their glasses or their phone or their purse, or, it can be a number of things. A TV remote is a common one. They may start doing things like putting, you know, non-food items in the fridge, or putting fridge items in the cupboard, or putting things in unusual places. And then when people can't find them, sometimes they'll buy multiples of that same item. Or even it's not uncommon that people, if they can't find things, so they're trying to figure out like what happened, and sometimes they accuse people like, oh, you took that, like that, I didn't lose it. So they might start accusing people of taking things from them. Another warning sign, so this is more a change in like behavior, mood, personality. We're getting to the B's, so A, B, C. So an impaired judgment or a change in judgment. So this might be something like risky decision making. So if someone, makes a impulsive purchase, or they gamble, or they're driving and they seem to be making, running red lights, or doing things that seem risky that they wouldn't have done before. And they don't seem to be aware of the risk, or they don't have insight into what the risks could be. That is definitely a red flag. Another common thing we see is people don't understand the risk of their medical problems. So say, they might have really bad pneumonia and they're on oxygen and they want to leave the hospital. And it's like, well, you're really sick. You have to stay here or you're going to be unwell. And they're just not able to recognize the severity, or how sick they are. Um, because of a change in their brain. And then so another concern is, people can get into financial trouble with this. So they might take out large sums of money, make these impulsive purchases, sometimes even get scammed, be a victim of scammers, unfortunately, because you just don't have the judgment to tell like, oh, this is a scam or this is suspicious. Which if you didn't have changes in your brain, you generally would have had. Another thing is if someone has had a big change in their personality or mood, this is a warning sign, and very common in many types of dementia. One thing we often see is these mood swings, or what we call lability. People can be flat, or their normal selves, and then it's just like a light switch. They can fly off the handle. They can get easily frustrated at small things, or the opposite. They might get really tearful and sad, and it doesn't seem like there was anything that provoked it. Um, if people are sort of uncharacteristically suspicious or paranoid, like again, people are taking things from me or something fishy's going on here, and they're really stuck on or hung up on that, that's a concern. People that kind of lose sometimes their filter, so they might be impolite or a bit rude, and that's not how they were before. Or sometimes people will start saying things that are quite rude, or things that they wouldn't have said in the past. So if people have a big change in their personality, that's a red flag. Another thing to keep in mind, another common change in personality we see is something called apathy or amotivation. So it's not just that people might lose their filter or have these mood swings. They might actually just lose their motivation, their get up and go, and they seem almost depressed. But with apathy, which is common in dementia, the person themselves is not troubled by it. It's usually the people around them that are like, what's going on? Like, why don't they have any get up and go? So just to keep in mind, changes in mood and personality can be more than just the, mood swings or more upsetting behaviors. Another one is loss of initiative. So people might start like not wanting to leave their house. They don't engage anymore in things they used to like to do. Hobbies, if they used to like playing cards or going out for certain things every week, they kind of start withdrawing. They have a difficulty initiating tasks like, reading a book or if people have different hobbies, it's like they just can't get started on those things and need more. Sometimes they find family has to cue and remind. It's like 1, 2, 3, or 4 times before they'll be able to do a task that before it, they wouldn't have needed to be reminded at all. Another warning sign is so we're into the C's, so communication or language changes. People start losing their words. So they can't find the word. They're repeating the same words. They might kind of say sentences that aren't grammatically correct. Sometimes they make up new words. Sometimes people will say, "Oh, the thing, that thing I'm talking about," and they just can't find their words. So they often use a substitute word like, "Oh, that thing," and they kind of dance around the word when they can't find it. Um, so a change in language is certainly something to watch out for. Another red flag or warning sign is difficulty with abstract thinking. So this might be like a common thing we'll ask people on some of these cognitive tests is to draw a clock, and they might not understand like what is a clock, like conceptually what is a clock and what is it, it tells time. What is it shaped like? Where do the numbers go? So there's difficulty with sort of that abstract thinking, or if you said like, okay, if you have, you're purchasing something that cost, $8 and you give them $10, how much change? So having to, hold that information in their brain and think about it and come up with, what is change? Is it, this many, a loonie and a quarter or a toonie, or what is it? It's very, very difficult for people to put that together if they're developing dementia. So those are the 10 warning signs. And again, changes in abilities, behavior, and communication, and the 10 warning signs within those categories. So what are the benefits of an early diagnosis? So an earlier diagnosis helps people understand the signs and symptoms. Probably most importantly, it helps rule out, is there something here that's treatable? Is there something affecting cognition that we can often like if people are on medications that are not helping their brain, if they have sleep apnea, if they have like a really low B12, or, there's lots of different things. Their thyroid functions out of whack, that we can try to correct that. The other thing is resources and support. So dementia is a really challenging disease, both for the people living with dementia, affected by the day-to-day symptoms and signs, and their loved ones. So to be able to understand what's happening and why, and not be left in the dark, because not understanding what's happening causes a lot of angst for people, is really important. And then future planning is huge. So, unfortunately, I see a lot of people that didn't really have access to a diagnosis, or they just sort of lived with these symptoms for years, and then a crisis hits and they end up in hospital, and they might need to move to a care home or long-term care, and them and their family, they barely even caught up with what's happening, and it all happens at once. If you have time to plan and prepare and understand and get things in place that need to be in place. Often that might delay an admission to acute care, or you may not, it may not happen altogether. So planning is huge. It's also really important to be able to communicate your wishes. And generally it's much easier to do that when dementia is in an early stage than when it's more advanced. And then there's also medications, so pharmacological and non-pharmacological approaches to improving quality of life in dementia. So how do you get a diagnosis? So it's important to know it's not just one test. So um, if you get like one memory test and the score is a little bit off, that doesn't automatically mean someone has dementia. There's a lot of things that can cause test scores to be off. Test anxiety. If someone, only went up to grade 6 or grade 8, they may not, score 100% on these tests, and that may have been the case throughout their entire lives. If people didn't have a good sleep the night before, if they can't hear or see well, there's lots of things that can affect the test. So that is part of it, is getting some form of cognitive testing. But it's also looking at people's medical history, doing a physical exam, doing some blood work to rule out, again, potentially reversible things. And then in some cases, there's like neuropsychology or neuropsychological tests, which is a more extensive form of cognitive testing. I'll also say it's not necessary for dementia to be diagnosed by a specialist. So we actually have guidelines that say dementia is ideally managed in primary care in most cases. So your family physician is always the best person to go to start. And in some cases, when things are more like an atypical presentation, or someone's younger, or there's something that seems more complex, certainly a referral to a geriatrician or neurologist or geriatric psychiatrist would be appropriate. But I just want to emphasize that it's not necessary, and every person with dementia does not need to be diagnosed by a specialist. In terms of what to talk to your physician about, I'll note here too, it's often the person themselves, but also it's important to bring family or friends or caregivers or whoever that person's primary support is to the appointment. One of the really tricky and tough things in dementia is the area of the brain that has insight into a change in abilities or some of these symptoms that are going on is often affected by the dementia itself. So people aren't willfully, not disclosing this information. They either simply can't remember it, or they're not aware that it's going on. So it's really important to involve, loved ones and friends and family, and try to bring them with you to the appointment and assessment. So things that your physician will want to know about is any changes in memory or communication, word finding, mood, personality, judgment. Are there certain things or abilities that people have lost or they're having trouble doing? How long has this been going on for? Is it like a week or two, or is this gradual thing over months or years? What pills and medications are you on? So this is both prescription and over the counter. There's a lot of non-prescription medicines that are really bad for the brain. So things like Gravel or Benadryl or some of these over-the-counter sleeping medications are what we call anticholinergics. So they literally block a really important chemical in the brain that is vital to having normal cognition. So it's important, if people are taking things over the counter, to disclose and those as well. Memory of a psychiatric history and family history as well, if there's a family history of dementia. So these are all important things to share with your physician. And there's also a really good website, abcdementia.ca, that has sort of a toolkit for how to get a diagnosis. So we'll quickly go over, treatment for dementia. So the biggest thing in dementia is, how do we provide this person with the support and help that they need to thrive in the environment that, they're in, or that is appropriate for what their specific care needs are? Because that may be different for everyone. Another really important thing is education. Like, what is this disease and what does it mean? How does it progress? How long does it generally progress over? What are common symptoms? How do you manage and live with some of those things? What are some strategies to make things easier? So supporting the person with dementia and their caregivers. Um, things like exercise, healthy lifestyle, as I said, things like getting hearing aids, making sure we've medically optimized everything we can, are all important. And then there are some medications we sometimes use. It's important to know, however, these medications don't actually help in mild cognitive impairment. So they've done studies on using things like Aricept or donepezil in people that don't yet have dementia, or they have this MCI that may never be dementia, and it actually doesn't have any impact on reducing the number of people that transform into dementia or not. So for those that have a diagnosis of dementia, whether it's Alzheimer's disease or these medications aren't as studied in some of the other types of dementia, but Lewy body dementia and Parkinson's disease dementia in particular actually have a fair bit of evidence for what we call cholinesterase inhibitors. So these first three here, donepezil, rivastigmine, and galantamine, are cholinesterase inhibitors. So they prevent breakdown of this chemical called acetylcholine. We know in dementia, there's sort of a deficit. The brain cells that produce acetylcholine are dying off. So we don't have as much acetylcholine. So if we give people a medication to help replace that, then that can improve, a little bit their day-to-day lives. It's really important to know, however, none of these medications stop ongoing progression of the disease. So they're not what we call disease modifying. What we're hoping for is in some people is we may slow down the progression. And unfortunately, it's not, it's not like we're gaining a decade of time. A lot of times, like the studies we have are if someone was on this medication for 5 or more years, you might get an extra 6 to 12 months at home or before needing to move into like a nursing, skilled nursing facility or long-term care by taking these medications. So they're not a cure. They don't prevent further deterioration, unfortunately, but they can give people a little bit more get up and go sometimes. Um, and slow things down overall. So there are certain contraindications to cholinesterase inhibitors, like they can sometimes cause some stomach upset, weight loss, slow heart rate, diarrhea, overactive bladder. So if you have any of those problems to begin with, these generally wouldn't, we wouldn't use these medications, especially because the benefits are so modest. It's not like, we're missing out on a very effective medication. So that's the cholinesterase inhibitors. Another medication we sometimes use is called Abixa or memantine. It's a generally fairly well-tolerated medication, memantine. It works on something called an NMDA receptor. Um, so it affects something called glutamate in the brain, which if you have too much glutamate, it can be a bad thing. So it helps regulate that process. The trouble with Abixa, it's very seldomly covered sometimes by private drug plans, but it's often over $200 a month. So it is often cost prohibitive in most cases. So these are some of the medications that, you could talk with your doctor about taking. And it depends on the person if, there's contraindications or not, and what the expected benefits would be. I thought I'd mention one of these like anti-amyloid antibodies that people may have heard in the news. There's actually a number of them now: donanemab, lecanemab, aducanumab. Unfortunately, these are not yet available in Canada. So Health Canada has not approved them. The FDA has in the United States. So this class of medication essentially is an antibody that attacks amyloid plaques in the brain. It's challenging because I think these are not benign medications. So on one of the studies done on lecanemab, what they did is they looked at amyloid levels in a couple ways. So either through lumbar puncture, they actually took the cerebral spinal fluid out and measured the level of this abnormal amyloid protein, or there's something called an amyloid PET scan, where we take a picture of the brain with a specific tracer where the amyloid protein lights up. So they measured that before and after 18 months of treatment with lecanemab, and they did see a 30% lower or reduced decline over that 18 months on treatment on cognitive testing scores. However, over 10%, so about 13% of people, they had these microhemorrhages or small bleeds in the brain or edema in the brain. So not insignificant. And the other thing, these are very expensive medications. So they're about $26,000 per year. Um, and the other thing we don't know, we don't have long-term data. So if someone, we know dementia is not a disease that only lasts for a year and a half. This continues on for often around, 10 years of progression. So if you took this medication for the first 18 months in early stage Alzheimer's, what happens after that? Like, do people over a course, if we looked at, say, not an 18-month outcome, but a 10-year outcome, is there actually any meaningful difference in these medications? And we just don't have that information yet. So this is something that may be coming in time, but um, unfortunately, it's not as the data is not as impressive as many of us hoped. So once we, have a diagnosis, we look at different medication options, non-pharmacological options. What do people do now? So one of the really big things and important things when people get especially when they get a new diagnosis, not necessarily only when you get a new diagnosis, is contacting the Alzheimer Society. So your doctor can make a referral, or even social work. There's lots of people that make referrals to the Alzheimer Society of Saskatchewan. You can also self-refer, and this is really important on getting more information about the diagnosis and what to expect and resources, and it really is helpful to have that additional support. Also, future planning is a really big thing. So, when you are in early stage of dementia, that is a time to make sure the power of attorney is filled out. It's got what you want on it. Filling out a healthcare directive and outlining what you might want or might not want in different circumstances. Appointing a healthcare proxy. Who is someone you trust to act on your behalf for medical decisions moving forward? Driving is another big thing to look at with dementia. So unfortunately, it's not a matter of if, but when people will have to retire or stop driving. As we know, dementia is a progressive disease, and it's generally easier if people, have some time to think about it, adapt, figure out alternate. There's lots of alternates for transportation depending on where you live. So that's something else that has to sort of be looked at. Making sure we're doing things that are safe. So, if medications are something people are having trouble forgetting, or they might be doubling up, is what kind of strategy can we use to fix that? Is it blister packs or dosettes or, reminders? There's lots of different things we can do to make medications more safe. And then, is someone in the right living environment? Is that, place they're at getting enough support, and, people are getting meals and their pills and, able to get, do to their day-to-day things with enough support? Or is it time to start learning about different places and what kinds of supports are out there? Um, so that's all I've got for tonight. I'll turn it over to Erica, and afterwards we'll go over questions. Thanks so much, everyone, for your attention.
Thank you so much, Megan. That was a great presentation. I hope that you can grab a drink of water. And if anyone hasn't put their questions in the Q&A, we please invite you to do that now. And in the meantime, I will just give you some information about the Alzheimer Society. So the vision of the Alzheimer Society is to live in a world without Alzheimer's disease and other dementias. And the mission is to empower all people to live well with dementia while funding research into prevention, cures, and quality of life through advocacy and awareness. With Alzheimer's Society resource centers across Saskatchewan, we served over 2,700 individuals from 300 communities across Saskatchewan just last year. I just want to note a couple things: that a person does not need a formal diagnosis to be connected to us, and we support those affected by Alzheimer's disease and other dementias and have resources and knowledge about many types of dementias. So you may be wondering what you can expect from the Alzheimer's Society of Saskatchewan. And there's a few things. The first is individualized connection and service, and that includes individual information and support, which is available for both people living with dementia and their care partners. We also offer learning opportunities, which includes the Learning Series courses, which are intended to help people with dementia, their families, and friends to live as well as possible with the disease. The courses offer build upon each other, covering the continuum of the disease, and also evenings of education, such as the presentation tonight, which are standalone topics presented by content experts. You can also expect connections, and this includes support groups. These provide the opportunity to exchange information with others living and affected by dementia, access the most current information, learn and share practical tips for coping with change, decrease feelings of loneliness and isolation, express feelings and be reassured that these feelings are normal, and find a sense of hope. We also offer our Minds in Motion program, which is a 2-hour weekly program that combines physical activity and social activity for those with early stage dementia and a friend, family member, or care partner. We also offer you connections to other organizations. This includes providing information on available services provided by the Saskatchewan Health Authority, other government agencies, and lists of private or community-based organizations that help support people's dementia journey. Our shift to also offering virtual and online programming, such as tonight's, has increased our ability to provide additional programs to many communities across the province. If you have questions about dementia or need someone to talk to, we invite you to call the province-wide toll-free Dementia Helpline phone number that is listed on the slide. It's available Monday to Friday between 8:30 a.m. and 4:30 p.m. I want to just briefly now talk about dementia research. So the keys to progress lie in investing in dementia research, revealing the mysteries of the disease and advancing diagnosis, treatment, and prevention more quickly. All research stimulates hope for the best life, and the Alzheimer Society of Saskatchewan funds research in partnership with the Alzheimer Societies across Canada through the Alzheimer Society Research Program. The Alzheimer Society of Saskatchewan depends on the expertise of the Alzheimer Society Research Program to allocate research dollars to innovative, peer-reviewed projects that focus on finding treatments, causes, and cures, as well as improving the quality of life for people currently living with dementia. The Alzheimer Society Research Program is Canada's most innovative hub for dementia research, helping the best and brightest minds in the field spark new ideas and transform them into impact for people. There are 4 types of grant opportunities through this program that research is funded by. The first is proof of concept grants. So this one helps support investigators with innovative approaches and projects with high potential or high risk and high yield. The second is new investigator operating grants. So these support new investigators within the first 4 years of their faculty position. Third is postdoctoral fellowship awards, and this supports trainees within the first 18 months of completing their PhD program. And lastly, we have doctoral awards. This supports students in the first 18 months of their PhD program. Lastly, I just want to mention and give you the fact that 3 out of every $4 that the Alzheimer Society of Saskatchewan receives comes from donations. These donations inspire hope to provide early diagnosis, greater awareness, for new medications and treatments, to provide strategies for coping, to provide care partners the confidence in their abilities, to continue to serve Saskatchewan communities with support and resources that are reflective of their needs. And these donations come in during events as sponsorships, gifts left and wills, monthly donations, or as general donations to the Society. So thank you. We will now get to our questions for the presenter, or for Megan. Okay. So, Megan, one of the first questions that we got was in the beginning when you were talking about sleep disturbances. And they're wondering how often do the REM sleep disturbances occur per night that might indicate Lewy body dementia?
Gotcha. That's a good question. It's a tough one to answer. There's not really a set number that would more so indicate this is a REM sleep behavior disorder. And in practice, I've seen a lot of different things. So generally, it's not every single night. I've seen people where they eventually get diagnosed with Lewy body dementia or even Parkinson's disease, and they had this for a few years and then it might sort of go away or get better. Some people it is about once a week. Some people it's every few months. So there's a huge variation in how often this can happen. The thing is that it is persistent and it's not going away. That would indicate REM sleep behavior disorder. So thrashing, falling out of bed, acting out dreams. The other thing to know is it's not always so if people move in there's lots of reasons people might move in their sleep. So things like narcolepsy, night terrors, restless legs, there's these periodic limb movement disorders where people's arms and legs can twitch. So if people are having this, it would be best to the gold standard test for REM sleep behavior disorder is through a lung specialist or respirologist. They order a level 1 sleep study in a sleep lab. You stay overnight and they, watch what happens and if you're in REM sleep when it happens. So it's a very good question. It can really vary how many times per month or even per year that people can have these symptoms when they sleep.
Thank you. The next is how common is it for delirium to occur with dementia, or is that categorized as a symptom of one of the varieties?
Gotcha. Great question. I'm glad we can touch on delirium. So, delirium is a acute confusional state, usually caused by some medical precipitant. So, infection, hospitalization, heart failure, a medication side effect. There's lots of things that could precipitate delirium. So unlike people might think of delirium as sort of acute brain failure, dementia, chronic brain failure. So one is a very short term thing that comes on quickly, and another is more gradual over months to years. So with delirium, it is more common in people with a vulnerable brain. So someone has a diagnosis of dementia. If they got admitted to hospital with some medical problem, say pneumonia, they're much more likely to develop delirium. So they might get much more confused than they're normal in hospital or get delirium because they have, a vulnerable brain or their cognitive reserves are already impacted by the other disease, dementia. So it's I don't know, I think it depends on what's causing the delirium, but I would say up to 30 to 50% of people who get admitted to hospital who have a diagnosis of dementia can suffer from delirium. So it's not in particular a variant or a variety of dementia, but another thing to know about delirium, it can happen in people who don't have dementia. So one study looked at, say, people in ICU. So when people are really medically unwell, it's more common to get delirium. And of all comers in ICU, a year later, 30% of them had enough cognitive dysfunction that it was consistent with what people would have with either a moderate severity traumatic brain injury or moderate severity dementia. So, these are young people, old people, older people with ICU delirium. So, delirium can cause irreversible cognitive decline and predispose people to developing dementia, depending on is it prolonged delirium and severe delirium. So, I hope that answers the question. It's very common that they occur together. People with dementia that live with dementia have higher risk of getting delirious, and unfortunately, it's not always fully reversible when people do get delirium.
Oh, thank you. That was very interesting. This next question is a little bit timeline specific. They just are wondering if it's harder to diagnose apathy or lack of motivation due to the pandemic and the changes in our human behavior from prior to post-pandemic, and within 3 years of developing alternative behaviors.
That's a great question. I would say yes. The pandemic changed all of our lives, and a lot of these activities and things people used to enjoy doing, just we couldn't. Things were closed, and even though it's been a few years now, not people haven't picked up, things in the same way that they did before the pandemic. So our lives are sort of been, permanently altered in just sort of the activities that we do and how much people go out. So yeah, absolutely. I do find that that has made things a lot more challenging. So is this, the person is apathetic, or is this like there's just less options for people to do things? In general, with apathy, the best way to sort of try to figure out what's going on is if they do have a family member that lives with them or knows them really well. If they're saying this is abnormal, there's something more to this, then that puts us in the direction of this is likely apathy, amotivation. This isn't just that, people don't have access to these things anymore. So, but for sure, it's been a shift for a pandemic shift in a lot of senses.
Yeah, thank you for that answer.
Yeah.
The next question is if you can give any tips of how people can talk to someone to convince them to have an assessment earlier, and what kind of is the process for testing or being referred to a geriatrician?
Um, yeah, so I'll start how do you convince people to go in for testing? This is sometimes quite challenging. Sometimes it's really not possible. Like it can be quite tough. I find telling people like if there was something going on that we could help you with, if there's something reversible here that we could fix, like wouldn't we all want to know? And it's not, it's not misleading to say that, because there are times where people genuinely, like, they may have a brain tumor. Like we really don't know if they're having a big change in their cognition or personality. They need to be seen and worked up and assessed. So sometimes to say like, this isn't just meant, I think a lot of people feel they're getting picked on. It's like you're getting dragged in to get this assessment. It's not meant to pick on someone. It's because people genuinely love and care about you and want to make sure, we're not missing something, and we're getting the blood tests and tests and scans and doing what's appropriate there. But admittedly, it can be really tough in some cases. In terms of process of referral to a geriatrician, it depends, I guess, where people live. So, right now in the province, we still need more geriatricians, but we have 3 in Saskatoon right now who are working, and we're lucky to have 2 in Regina as well. So in Saskatoon, we're as geriatricians working out of the GEM clinic at City Hospital. So the process is just to get a referral from your family physician or nurse practitioner, if you're able to come into Saskatoon. And then it'll be triaged, at GEM. Not everyone is triaged to see a geriatrician just because there's so few of us. So if people are more medically complex, or there's something more abnormal going on that might require more in-depth assessment, they'll be triaged to geriatrician. Otherwise, that we do also have family physicians and really great allied health that work together to diagnose people. And in Regina, under the geriatricians are working out of the Wascana clinic. So the referral would be from your family physician or nurse practitioner to see a geriatrician there. I believe there's also memory clinics, or what they're calling MINT memory clinics, that are popping up. So that is another very good option if people are, not able to come into Saskatoon or Regina. And I'm hoping in coming years we'll be able to expand that. And then there's also RADAR, or the rural dementia clinics, that are more in the south of the province. So there's a lot of different avenues to get assessed. that aren't just geriatricians. I just want to emphasize that too. But that would be the process for, I can speak to Saskatoon anyway, how to get a referral to get seen.
Thank you. And I know if you want more information on the memory clinics, you can contact us here at the Alzheimer Society and we can point you in the right direction for that. The next couple questions are related to risk factors. So the first one is asking if you can kind of give some more background information on why lower education is a risk factor for dementia.
Mm. It's a really good question. It's not, I think these are things that are probably multifactorial. So, um, um, sorry, noise in the background, but it's, I think, somewhat to do with cognitive test scores. So, things like some of the more complicated neuropsychological testing and things. Generally, if people have taken more advanced education courses, they will score higher on some of those tests. So some of it may be a bit, of overdiagnosis sometimes. I do see that where people, they score lower on cognitive tests, so they get labeled with dementia, but they're actually functioning fine. And you see them 5 years later and they're still functioning fine. So that's one part. The other piece may be people with lower levels of education. This is, again, just from what I've seen in practice, may be more likely to work in jobs where they may suffer more injuries or develop more medical conditions. So, they may get a head injury at a younger age. So I think it is more to do with, people's overall lives. It's not just the education, but that's sort of something we found that's linked with developing neurodegenerative diseases. But I don't think it's, I think of all the risk factors, that's probably one that's lower down on the risk of being a convincing risk factor. Like the microvascular, like the vascular risk factors are much more important. Things that we do that might damage the brain with blood vessels or head injuries or smoking or those sorts of things. So I think that's it's a tricky question. It's not entirely clear, but I think there's probably a number of reasons there could be an association there.
The next one kind of relates to what you just mentioned and how we have actions that we do ourselves that damage the brain. And someone just wants to have some clarification on the relationship between alcohol and dementia.
Gotcha. So yeah, it's we've had these new alcohol guidelines come out, which essentially, used to be quite a bit higher, and now I believe it's something like 2 drinks or less a week is really what's recommended. And what the data is showing is that any amount of alcohol increases risk. So essentially, alcohol, as we metabolize it, turns into this chemical called acetaldehyde, which is a direct toxin to the brain. Also, the heart, the nerves. So, in high amounts, you can get neuropathy or nerve damage. You can get cirrhosis. You can have damage to the heart muscle and the brain. So, alcohol, unfortunately, can damage tissues in excess over a long amount of time, long period of time. That damage can be cumulative. So it's also a bit tricky because I think with alcohol, we see that people really, I think there's probably some genetic risk factors. So some people can drink a fair amount and really not have many health sequelae. Some people can drink a moderate amount and run into trouble with, say neuropathy or damage to their liver. So another thing with alcohol that's come out too is there is a higher risk of certain types of cancers with alcohol use, particularly like breast cancers or esophageal stomach cancers, pancreatic cancers. So that's not necessarily linked to dementia, but we do know that the more medical problems people acquire over time, they become more medically frail. Physical frailty is associated with developing cognitive problems as well. So that I think that's another pathway that alcohol intake can be linked with dementia, that people if they have a whole bunch of medical problems piling up, they might get delirious. They might end up with some cognitive impairment as well. It's a great question.
Yeah, thank you. The next question relates back to the warning signs and the symptoms that people are experiencing with dementia. So, would a person have to have several of the warning signs from the ABCs before they should see a doctor for assessment, or when should people really be concerned?
Yeah, that's a good question. In general, like, yes, you should have more than one, small change. It should be the big thing with dementia is this is a change from someone's normal level of function or their say their normal personality, the tasks that they normally do, they're starting to have trouble with. So if that's going on, that's definitely a time when people should be assessed. There are some, like what we call normal cognitive changes of aging. So, one thing that's quite common is people have more trouble multitasking. So, it's not uncommon or abnormal, say, if you leave the house without your keys or you misplace a TV remote once in a while. If you're doing that all the time, that's worrisome. But if someone takes a little longer to pull out a word, but they can find it and nothing else is going on, that's not necessarily a problem. Or if, as I said, if you're in an unfamiliar city or part of town and you make one wrong turn, that's in and of itself, that single thing is not a reason to jump to concern. But if you see things over, time that are adding up and it's more than once that things are happening and it's generally more than one warning sign, definitely that would be the time to go in. But, um, word finding difficulty is fairly common with aging there. And sometimes that can be the medications, like people get started on a new medication or there's you know other things going on, so it's hard to answer that question, but in general, yes, like people would have more than one warning sign and it would have to be persistent, not just like a one-off or they had a bad day or a bad week or something.
Yes, thank you for that clarification. So, now on the opposite end of the spectrum, how can you tell when someone is entering the later stages of dementia?
Yeah, so later stage dementia, again, it depends on the type of dementia, what people's symptoms might be. But what, in general, some common things people might experience, they may start forgetting people that are close to them. So they may not recognize close family members or what their names are, or they might recognize someone's familiar, but not be able to place exactly who they are. That's a more later stage symptom. They may start having what we call motor symptoms or difficulties with walking. So they start falling a lot. People might not really know like how to figure out how to use a walker, or they might become confined to a bed or wheelchair. Um, People generally start losing the ability to speak. So they might only be able to answer in like short phrases like yes or no, or, string a few words together, but not, communicate in robust sentences. Generally is later stage. People tend to lose a lot of weight. So people can, kind of lose their appetite. They can have swallowing dysfunction or dysphagia where they can't get their food down. They might start choking on their food where it goes into the wrong tube. People can get aspiration pneumonia, which generally won't be a reversible thing, or it'll keep happening because the swallowing, the brain can no longer tell, those muscles how to coordinate and how to swallow. So those are, a few symptoms of fairly late stage dementia that would indicate someone is nearing, more closer to the end.
Perfect. I just have a couple questions left. So if you haven't had your question answered and there is one you want to ask, we feel free to enter that now. Or if you have any follow-up questions, you can always contact us at the Alzheimer Society. Again, people are just kind of asking for the best approaches that you can recommend about people who are in denial about their warning signs or diagnosis.
Oh boy, this is such a tricky spot for loved ones to be in. I think
Mhm.
if you can get people in to see their physician, um, sometimes it doesn't have to be an extensive conversation of why they're going in. Um, to just say we're doing this because we care about you. We want to make sure we're not missing something. There could be something medically wrong going on. It really can be a struggle um, sometimes to have people um, present for an assessment. The other thing is, I always say redirect, don't correct. So if people are really doubling down, try not to engage in an argument. So it just won't be fruitful to sort of sometimes you just simply won't convince someone. So I think a lot of times people feel like I have to convince someone that this is what they need. Like I think what I found is sort of a more general approach of we love you, we care about you, we want to make sure we're not missing something. You need to see your doctor and get checked out, is more fruitful than trying to convince people that something is going wrong with their brain because they simply won't agree with you, unfortunately. So I wish I had like just do the simple thing and it will become easier. But that's sort of from what I've seen sort of works the best is try not to get into sort of a heated argument about, but just sort of redirect, change the subject, come back to it, keep it more general as to why someone needs to be checked out and assessed.
Thank you. We have one more question, and it regards to risk factors again. And people are just wondering if there's a geographical difference in where someone lives as a risk factor. So certain neighborhoods or countries, for example, if you could maybe speak on that.
Yeah, it's a good question. I think in general, no. Like for dementia, because there's so many different subtypes. As a whole, I believe, overall, most countries would have fairly similar rates of dementia. We don't have a lot of data. Like there's certain countries that simply just don't report a lot of data and statistics, so that's a bit of an unknown. But I would say in general, there's certain illnesses like say multiple sclerosis. We know the higher north, in some cases, people live, the more likely that illness may be. So dementia doesn't seem to be one of those diseases. And simply, as I said, I think because there's so many different subtypes, they could occur, no matter where people are living.
Yeah, thank you for clarifying that. And again, thank you to everyone who attended tonight. And of course, thank you to Megan. Um, Just reading. Oh, I thought another question popped up, but it didn't. Sorry about that. And if your question did not get answered tonight or you have follow-up questions, I encourage you to contact one of our resource offices or call the Dementia Helpline at 1-877-949-4141. So thank you, everyone. I hope you enjoyed the presentation and good night.